a history of the present illness, which is called as onset, duration, and progress. So you want to say this is a 35-year-old male who has a history of back pain for the last 3 months and a history of right lower limb pain for the last 1 month. That is the chief complaint. After the chief complaint comes the history, where in history you will now go into the details of the chief complaint. How did it start? Was it acute onset? Was it gradual in onset? Was there an inciting factor which started it or not? Is there an aggravating factor? Is there a relieving factor? How has this problem progressed over the period since it started to today? And what are the functional limitations it is causing? All of us have back pain. We all still go about doing our work. So it's not a functionally incapacitating back pain. But you have a back pain which is not able to let you go back to work, then it is an important back pain and you should be aware of it. Because ultimately the goal of your treatment is what? What is the goal of your treatment, doctor? You are a doctor? Orthopedic surgeon? Yes. Resident? Yes. To get patient back to his life. Absolutely. Fantastic. Very good. So basically the goal of treatment is to restore his normal activities and life. So if we can do that, we must know what is his functional limitation now, so that we can restore him to whatever it was. So this is how the onset, duration, progress of a current illness goes. Then comes the history of etiology of complications. So if a patient with back pain, what is the complication? Has he got bladder bowel complaint? Has he got any discharging sinus somewhere which you can see? Is there any swelling somewhere which is a complication? Is the patient paralyzed because of in the legs because of that? So that is a complication. So you want to find out history of complication. You want to go into the history then of etiology. Remember, in an exam you have limited time. So you have to present your history very effectively. Every negative history you don't go through. Sir, no history of fever. This is how people speak. No history of fever. No history of, sir, trauma. No history, sir, of anorexia. No history of weight loss. Why have you repeated no history 5 times? You have wasted that much time. Huh? Your exam is going to be there for 15 minutes. People say, sir, मैं सब कुछ बोला लेकिन मेरे को फेल किया. तो क्यों? तेरा दुश्मन है वो फेल करेगा तेरे को? तो फेल हुआ क्योंकि in your exam the examiner spoke more than you. You should be speaking more than the examiner. You have to display your knowledge. If I have to ask you every question, that means you have failed. If I have to ask you and make you speak something out of your mouth, then it's a problem. So you take your history, take these things, go into history of etiology, then you go into all this personal past, family history, कुछ relevant नहीं है तो कुछ, sir, his personal relative history is this thing, he smokes 1 cigarette a year, how is that relevant? Right? Just leave it, no, don't talk about it. Right? So talk about things which are relevant. Sir, he has no family history, but he has 3 siblings, all of whom are alright, so why talk about it? If the siblings are okay, why talk about it? So, learn to speak sensibly and rightly. If at the end of your history, the examiner doesn't stop you, don't wait for the examiner to ask you a question. You go on to your examination, start your examination. Go in a systematic manner, continue your examination. If at the end of examination, he asks you, what is the diagnosis? Great. If he doesn't ask you, you continue with the diagnosis. Don't stop. You are like a mail train. You have to, out of 15 minutes exam, you have to speak for 12 minutes. Examiner should speak only for 2 to 3 minutes. Then you have reached your goal. Okay? So this is just some basic insights. We'll give you insights as we go on. And today I am going to talk to you about how evaluation of the spine must be done in this. अरे वो किधर गया तेरा पेन? इधर तो नहीं दिख रहा है. Alright, so we'll talk about evaluation of the spine. The diagnosis of a spinal problem is mainly done on history. 80% of the times the diagnosis is achieved on history alone. The examination serves to only confirm your diagnosis on history. It tells you how severe the problem is and helps you plan your treatment. And therefore the key to treatment is evaluation on history. When you start a history of spine, you want to know whether the patient has pain or not. If the pain is there, is it back pain or neck pain, which is called as axial pain, or is it pain which is going down the legs, which is called as radicular pain or referred pain? If there is pain, you want to know how did it start? Was it gradual in onset? Was it acute in onset with some history of trauma or something? What is the duration since when it started, and how has it progressed since then? Has it gotten better? Has it gotten worse? Are there new symptoms? These things must be talked about. The next thing you want to know about is this continuous pain or is it intermittent pain? Why is that important, doctor? How do you, if patient has continuous pain in the back, what do you interpret? And if it is intermittent pain, what do you interpret? Yeah, pain gets relieved then. If the pain is intermittent, then what? Anybody, chalo, chhod do. Anybody, if pain is intermittent, what? And if pain is continuous, what? Okay. Could be. Anybody else? Yes, doctor, you want to say something? Anybody else? Very good. So that is there. But what happens with continuous and intermittent pain is the pathology differs. Intermittent pain is pain which appears with certain postures. It occurs with certain movements. This is called as mechanical pain. Okay? And continuous pain is what is called continuous. This is biological pain. Okay? It is not affected by the stability of the spine. It is affected more by the presence of a disease. Typically, continuous pain you find in inflammatory conditions or infective conditions, in tumors, and when there is severe destruction of the spine. Whereas intermittent pains you will get when there is disc prolapse, lumbar canal stenosis, or spondylolisthesis, which are mechanical back pain is there. The next thing you want to do is to find out what are the aggravating and relieving factors. So certain patients will complain of pain which is more when you stand and walk. What would you conclude, doctor, after that? If the patient says, sir, when I'm lying down, I'm sitting, I'm absolutely fine. But when I stand and I walk a distance of 15 minutes, then I start getting pain down the back or legs, and then I have to sit down. What is that pain?
Claudic.
तो ऐसा सोया तो मैं पकड़ेगा. I could see you are not interested in what I was talking. That's why I asked you the question. Okay.
Claudication.
I'm seeing everywhere. किसी को छोड़ूंगा नहीं.
Claudication.
Claudication. Very good. So this is neurogenic claudication in a patient with lumbar canal stenosis. So it gives you aggravating. Certain patients will say, doctor, मैं खांसी करता हूँ तो बहुत दर्द होता है और पैर में दर्द चला जाता है. Classical, which you find in a lumbar disc prolapse where there is a compression of the nerve. So these are some of the things that you want to know from the patient. Radiculopathy. The next thing you want to know is the patient's pain only in the neck, or does it go down the upper limbs? Is it only in the back, or is it going down the lower limbs? If it is going down the legs, is it referred pain or radicular pain? What is the difference? Somebody referred pain or radicular pain? Madam, even ladies are allowed to speak in this audience. We are not discriminating. What is the difference between referred pain and radicular pain? Anybody?
Referred pain.
Yeah, tell me.
Referred pain means the pathology is somewhere and the pain is somewhere else.
Very good.
And radiculopathy means the pain radiates to from the origin of pain and radiate to somewhere else.
Very good. So essentially, right? So there are essentially three types of pain. There are radiating pains, there are referred pains, and radicular pains. Radicular means along a nerve root distribution. It is along. So suppose patient has pain which is in the buttock, going down the posterior thigh, posterior calf into sole of foot. Which nerve root is affected?
Sciatica.
Say sciatica तो मालूम है which nerve root? Nerve root बोल रहा हूँ. L4, L5, S1.
L5
अभी L1 पे आ जाओ. तो एक ही तो बच्चा है.
L2 है.
So, see where you people are. You all are third year residents? Second year में तुमको मालूम नहीं है कि S1 distribution क्या है. Okay? So S1 distribution is along posterior thigh, posterior calf, and sole of foot. L5 can be posterior buttock, but it comes down the lateral thigh, lateral calf, and on the top of the dorsum of foot. So that is L5. Okay? So you should know that. So that is radical. You should know these distributions, but it leads to your diagnosis. So many times you think, sir, आजकल तो MRI है. Why should we know all this? Because so many times you see on MRI there is a small L4-5 disc. You think that is the cause, but the nerve root distribution is S1. Patient is not matching, and then you will operate on the wrong level, and patient will continue to complain of persistent pain. Though you will think at the end of the day, sir, मेरा तो पैसा आ गया ना. Sir, that is not the way we want to treat our patients, right? So, what you need to realize is there is a radicular pain along the nerve root distribution. There is a referred pain. Referred pain means a pain, as he very rightly said, which is not in direct contact with the primary source of pain. So it is referred from the back. If a patient has facetal arthritis, often the pain will be referred to the front or the back of the thigh. That is called as referred pain. Whereas radiating pain is in continuity with the primary. So if I have pain over here because of a faceted arthritis, and it is going along here, that is a radiating pain. It's radiating out from the primary source of pain. So you want to know whether it's radicular pain, referred pain, and radiating pain. You want to know the location of the pain. You want to know whether there is associated paresthesia, numbness, or weakness. Why is that important? We know he has leg pain. Now why do I need to know whether he has paresthesia, numbness, and weakness? Anybody? कोई third year resident कौन है इधर? कोई है ही नहीं third year resident. तो आज present कौन करने वाला है?
So these are third year, they have just become third year.
They have just become, so they don't want to admit it. They are quad में छिपे हैं. But I know you are out there, my friends. I'll get you. All right, tell me. So basically, when you have pain, it is an inflammatory process, or which is affecting that the nerve is affected, and it is not a happy situation for the nerve. That is pain. But the nerve is still conducting impulses. At a later date, when the impulses start stopping getting conducted, that means the nerve fibers are now getting damaged, and therefore patient is developing weakness, numbness, paresthesia, loss of reflexes. All this happens because of that. So it was from a radiculitis, you are moving to a radiculopathy. Okay? You want to know whether it is continuous pain or intermittent pain. You want to know what are the aggravating and relieving factors. Bladder or bowel incontinence, frequency, urgency, hesitation, reduced sensations in the perineum are all signs of compression of the conus or cord and should be looked for, and if they are, then you think of it as a cauda equina syndrome, which is an emergency. As I said earlier, you want to know the function of the patient. What is the current level of disability? Sir, because of his hip pain, he is not even able to walk 5 meters. Previously, he used to go for 5 kilometers. So that is the level of disability, functional limitation the patient has. Okay, and you want to know why he is not able to do it. Some patients say, sir, so you are all ready, he is not able to walk even 5 meters. And this guy has pain. Must be some big pathology. I am ready with my knife for surgery. And then you ask him, why you don't walk? नहीं sir, थोड़ा breath सुबह दमा चढ़ता है इसलिए मैं चलता नहीं. Right? And then you realize कि अरे Papa, you lost this pain. This guy is not going for surgery. You go to the chest physician. Right? So etiology. You then want to know if there is a history of trauma, fever, weight loss, anorexia. So I never in the exam expect you to say, sir, no history of fever, no history of fever. You say, sir, history, no history of Cox or Cox contact. Then if I want to ask you what is the history of Cox, I'll ask you. Why do you want to put your foot in and give everything and waste your time? Sir, no history suggestive of rheumatoid arthritis or any inflammatory arthropathy. If you tell me that, then you don't have to say multiple joint pains, morning stiffness, all these things. Past history of any medications like steroids. Why is that important? Why is the history of steroid taking important? Anybody?
Avian.
Avian of the hip, fantastic. What else? Osteoporosis and is a very frequent problem with steroids. Very good. So you want to know whether there are any other illnesses in the past like a malignancy and HIV or etc. And you, in a child, you might want to know the birth history if that is relevant. You want to know the past history of similar episodes. That is very important, and how it was treated and how did the patient get relief of symptoms. Because you can get an idea as to how the patient was treated and whether he can be treated. I'll give you a simple example of how it works. When I was in first MBBS, there was, how knowledgeable MBBS students are, right? So I had this girl in my building, very pretty, and I was trying to desperately impress her at Patao. One day she came up to me and said, Gautam, I've got this small circle over here, rash jaisa hai. So can you look at it? So I looked at it. I held her hand for 5 minutes. I felt it. ऊपर से फील किया, नीचे से फील किया, सब कुछ हो गया. Then she said, अभी क्या लग रहा है? मतलब ऐसे तेरे को अभी आए, what will I know as a MBBS student कि क्या लग रहा है मेरे को? तो मैं बोला कि ऐसा तेरे को कभी हुआ है पहले? कहा एक बार हुआ था. मैंने तभी क्या किया था? नहीं तभी ये मेरे को डॉक्टर ने लोशन लिखा था उससे अच्छा. So that's right. That's the correct treatment for this problem. उसको लोशन लगा सब ठीक हो जाएगा. So she got better, and then of course it worked out for a few years. So similar episode in the past, relief from the symptoms at that time is extremely important. It guides your treatment. Okay? Once you finish your history, ideally you should have reached a diagnosis. And now is the time to go on to examination. And examination follows clear pattern. You start with the floor. Any systemic, any joint examination follows the principles of look, feel, movement, measurement, neurological and other systems. The spine is special because it houses two systems: an orthopedic musculoskeletal system and a neurological system, and therefore your examination should have involve both the musculoskeletal part also and the neurological part also. So you have to do this examination. In inspection, you look at the sagittal and coronal balance, localized deformity, bony prominences, spasms, any scars, sinuses, dilated veins, swellings, and ulcers. On palpation, you always start by examining for local warmth, then check for tenderness, and then confirm your inspectory findings. On movements, you check the movements in various planes at all the joints, and you look for the gait. And in measurements, you do measure the amount of flexion, what is called as the modified Schober's test. We'll get there. Neurological examination, you do two types of tests. There are tension signs and there are compression signs. Tension signs means signs that the nerve root is irritated. The nerve root does not like what is happening to it. That is a tension sign. The compression sign means the nerve root is now no longer functioning effectively. So there is motor weakness, there is sensory loss, there is loss of reflexes. So these are compression signs. And finally, do not forget to examine other systems. About 25% of all patients who have a lumbar degenerative spondylosis will also have a cervical spondylosis. So you must examine the entire spine in any patient with a spinal problem. The sacroiliac joint is extremely important because sacroiliac joint can result in back buttock pain and even radicular leg pain, which is very similar to the pain that the patient gets with spinal problems. So I'll give you this example. A young 22-year-old boy once came to my clinic. He had severe buttock pain, unrelenting in tears. He had a horrible facial rash. It was a pustular rash which was weeping. You could not bear to look at the guy, he was so ugly. Now, the question was, he had gone with this pain to an orthopedic surgeon. The orthopedic surgeon got an MRI scan done and he said that, oh, I think there is a small disc here, we should go for surgery to relieve the pain. The patient got frightened and went to a physician. The physician said, there is nothing, I think we should start you an empirical anti-tuberculosis treatment. So, patient was now confused. So, what did he do? What did he do? Anybody? He did the smart thing. He came to me. Okay? And when he came to me, I examined him and I found tenderness over the sacroiliac joints. So I thought this is this thing. The problem was he had MRI was only 3 days old. Now it did not include the sacroiliac joints. So now to convince him to do a fresh MRI was very difficult. But somehow he got convinced. We got an MRI sacroiliac joint, florid bilateral sacroiliitis. This was a patient who was presenting with his early episodes of ankylosing spondylitis, starts with sacroiliitis, and this is what it was. And we diagnosed it, we treated it, his pain in the hip went away, but even his faciopustular rash went away because it's an autoimmune condition. And he was one of my happiest patients. But there are sad stories too. There was the 36-year-old priest who was admitted under a very senior orthopedic surgeon. I was very new in practice. I was once told that, Gautam, there is a patient with a L5-S1 disc prolapse. You have to come and operate the patient. So I did not see the patient pre-op. I went and operated the patient, did a nice discectomy and came back. As would be the case, 3 days, 7 days later, I get a call, Gautam, patient is not very happy, come and see the patient. So if everything goes well, then you are never called. But if anything goes small is wrong, then you are to blame. So then you get called in the front. So I went there. When I examined the patient, I found that he said he had two pains. One pain was posterior buttock, thigh, calf, and there was a second pain going down the groin and medial thigh. He said my posterior buttock, thigh, calf pain was gone after the surgery. But that medial groin thigh pain is still existing. So I examined him and I found his hip rotations to be restricted. I asked for an MRI of the hip joint and he had avascular necrosis of the hip which was pre-existing. So he had both complaints, both needed to be treated. But because his MRI, his AV and hip was missed, he was very upset and he stopped following up with this. So this is very important that you must examine other systems. In a cervical spine, always examine the shoulder joint. In all spinal problems nowadays, knee osteoarthritis and lumbar canal stenosis or degenerative back problems are so commonly coexisting. Examine abdomen and chest. You will see a fire. So there was this 22-year-old techie. He was not a techie, shippy. He was in a ship, merchant navy ship, which was off the coast of China, near Shanghai. And he started getting some pain in the right hypochondrium. And it was pain, so he went to a hospital in China, in Shanghai, and Shanghai they told him that you have gallstones. And they advised him to undergo emergency laparoscopic cholecystectomy. But Indian patients, being Indian patients, they are always smarter than the doctors. So he decided that this Chinese guy doesn't know. And in this case, he was smarter. And he came to Bombay and obviously did the smart thing and came to me. And when he came to me, I examined him and I found some tenderness over the spine. But what I also found was that there was some subtle brisk reflexes in the lower limb. So I suspected that there was a pathology in the dorsal lumbar junction, and I sent him for an MRI. MRI showed a large space occupying lesion within the canal, and it was engulfing the right sided nerve root at D12, and that was the cause of his pain. We operated on his pain for the spinal tumor and charged him twice. Once for his spine problem, once for relieving his right hypochondria. Right? I'm just kidding. So the last part of examination is to examine the peripheral pulses. You always hear about doing peripheral pulses in all extremity examinations. But examination of peripheral pulses is equally important in a spine exam. Again, similar story, 69-year-old gentleman came to me from Surat, and he had been referred for surgery for lumbar canal stenosis because he had claudication pain. Somehow his history didn't look very good. When I was looking at him, I could see his lips were black from smoking. Hands were also, typical smokers. I said, this is not proper. So I put my hand on the dorsalis pedis, could not feel it. Then I tried the posterior tibial, could not feel it. I immediately sent the patient for a color arterial Doppler. The patient has a large thrombus sitting at the bifurcation of the common iliac artery, a condition called as Lerich's syndrome. Okay, Lerich's syndrome, and he required emergency thrombectomy. So sometimes if you are careful, you will not miss out these diagnoses. So examination always should be done. So in inspection, you always start by looking at the patient from the front and the side. What you want to see is the balance. There is the coronal balance. From the front, the chin should fall over the pubic symphysis. From the back, the inion should fall over the anal cleft. That is normal coronal balance. If it deviates to one side or the other, which is the condition in which it will deviate? Anybody? Scoliosis. Very good. So you will find it in scoliosis that it deviates. Similarly, a balanced posture when you look at a person from the side is that your pinna falls over the shoulder, which falls over the hip, which falls over the malleolus. Now, if instead of this pinna falling over this, it falls forward in front of the spine, what condition is that called? Kyphosis. And if instead of that it is like this, okay, what is that condition? Hyperlordosis. Okay? So we are looking for these conditions when we see. One of the other coronal plane deformities that you see is torticollis, a lateral tilting of the head. The head is tilted to the side of the sternocleidomastoid contracture. The face is rotated onto the opposite side. In chronic patients with chronic elderly patients, 10, 12-year-old kids, you will often find they'll have nystagmus because their head has been fixed in this direction, they're looking like this, they may get nystagmus. Typically there is fascia, the face of this half, which is the torticollis side, is not well developed, it is hypoplastic. Extension is restricted, movements are restricted, the lateral bending is restricted to the opposite side, and rotation to the same side is restricted, and you might find a tight contracture of the sternocleidomastoid. There are very many causes, you must look for them. What is also important is there are very many associated conditions. Cervical scoliosis may be present. There is a condition called a Sprengel shoulder. What is that?
High riding scapula.
High riding scapula. This is the khasiyat of Indian teaching. If I ask you 10 causes of low back pain, you won't know. But if I ask you what is high riding Sprengel shoulder, you know. जो 1 लाख में एक जन को होता है वो मालूम है, लेकिन जो 9,000 में 900 को होता है वो मालूम नहीं है. Okay, what is Klippel-Feil syndrome? Short neck with what? So Klippel-Feil is a syndrome where there are multiple congenital cervical file fusions. Okay, and along with that you get a short web neck, webbing hota hai neck ka, and a short and a low posterior hairline. That is classical of Sprengel shoulder and Klippel-Feil syndrome, and is frequently associated with Sprengel shoulder. Okay, now here is the award-winning question, first to the residents and then to their teachers over there. Name one cricketer famous international cricketer who had triple file syndrome? Chalo, first the residents. Anybody? Most of you, it will be before your time, so you may not know, but tell me. Anybody? Huh? Lasith Malinga? No, unfortunately. Anybody? Yeah. Shane Warne, nahi re wo.
John Gardner, recently.
No. Anybody else? Sir? Right?
Small. The bowler in England.
Excellent.
Gladstone Small.
Gladstone Small. Fantastic. Good. So there was a cricketer called Gladstone Small. He was a African English person, and we call Negroes as African English these days. So this is, and he used to bowl like this. A very effective bowler. Along with that, we look for high arch palate, high cleft lips, and look for CDH, CDK, and CTV in these patients. Now, you look for scoliosis. I said, what is scoliosis? Scoliosis, by definition, is a lateral curvature of the spine which is more than 10 degrees. But you must understand that scoliosis is actually a three-dimensional deformity. It involves rotation, it involves flattening of the spinal thoracic kyphosis, and it involves a curvature in the coronal plane. How do you diagnose scoliosis? What is the easiest method to diagnose scoliosis, doctor? Don't look down. तेरे को ही पूछ रहा.
Inspection.
तो करना ही पड़ेगा. Examine नहीं करेगा तो कैसा पता चलेगा? That is not something unique you have told me.
Inspection.
One test. Adams, what is Adams forward bending test? It is a short note in your exams, huh? Yes, so the examiner sits behind the patient like this, okay? And the patient bends slightly in front of him. Now, because it's a three-dimensional curve, what happens in scoliosis, on the side of the convexity, there is a rotation. And because of the rotation, the ribs become more prominent and forms a rib hump. When you bend forward, you will find that the ribs on one side are higher than on the other side. That is called as Adams forward bending test. Being positive, it is very sensitive and it can detect even milder degrees of scoliosis. So you must know, read up everything about Adams forward bending test. It is you frequently asked as a short note in your exams. Otherwise, when there is a slightly more prominent scoliosis, you may find the head is shifted to one side, the shoulders are higher on one side compared to the other. You can see over here that the scapula are at different levels. There is a deepening of the central furrow. There is an asymmetric waist. This hip is sticking out. This is gone in. There may be leg length discrepancy, and you must always examine for secondary sexual characters. This is the Adams forward bending test. As you can see, this is the rib hump. Oh, sorry. Right. So, and then you want to check the flexibility of the curve. In a small child, you can check the flexibility of the curve by called traction test. The child is made to sit on a table. You stand behind the child and you hold the child by the neck, gently pull it and see whether the curve is straightening out or not. That shows you whether the curve is flexible. In older patients, you can do a forward bending, and even the forward bending may allow some correction of the curve, and it will tell you whether flexible. But the ideal thing is to do X-rays to see flexibility of the curve. Okay, there are many different causes of scoliosis. We have, I don't know, some of that stood up. And the other case condition is a kyphosis. A kyphosis is an increased forward bending of the spine. You can find there are, depending upon how many vertebrae are involved in the kyphosis. If a solitary vertebra is collapsed, like it is in an osteoporotic vertebral fracture, then only one spinous process is more prominent or palpable at the back. That is called as a, what is that? Knuckle. Very good. एक ही जन आज पढ़ के आया है. बाकी कोई पढ़ के नहीं आया है, हाँ? If there is an infective spondylodiscitis like in tuberculosis, vertebral disc is gone, two adjacent vertebrae are involved. Now you are finding two prominent spinous processes. What is that called? Gibbous. And if there are multiple spinous processes which are palpable and prominent, like in this child, what is it called? Kyphus. So you look for knuckles, kyphus, and all that. Now what happens normally in any human being when a person develops a thoracic kyphosis like this? What happens? Does he fall over? Why? What compensates? Lumbar spine compensates. Thoracic spine अगर kyphotic हो गया, first thing that will compensate is the segments above and below. So the remaining thoracic spine will go into hyperlordosis. If that is not enough, then cervical spine will go into hyperlordosis. Lumbar spine will go into hyperlordosis. If it's still the kyphosis is so much that even that compensation doesn't happen, then the pelvis starts derotating. The anteversion of the pelvis goes into retroversion. Okay? So body tries to compensate for this as time goes on. Now this is very much possible in a child with tuberculosis because spine is flexible. But in a patient with ankylosing spondylitis with kyphosis, this is not possible. So what happens? The compensation all occurs at the level of the pelvis, where the pelvis goes into retroversion. As the pelvis goes into retroversion, what happens? The patient is falling back. He doesn't want to fall back, so he flexes his hip and knee in order to get the patient back into balance. So this is how he becomes flexed hip, flexed knee. This is called as a Mr. Punch posture is what he developed. Okay? And here you check occiput to wall distance and chin brow to vertical angle. So these are kyphosis. This is how you detect milder deformities by making the bend forwards. There are two types of kyphosis, angular kyphosis and rounded kyphosis. The most common rounded kyphosis is postural. I have all these young boys who come to my clinic. You see that their pants are below their waist. I can see their Calvin Klein over here, and they are all standing. They are very cool dudes. They are all walking in this posture, right? So this is typical what you find in this thing. In older individuals with vertebral wedging because of osteoporosis and disc space collapse, you can get senile kyphosis. And then there are conditions like ankylosing spondylitis, Scheuermann's disease, etc. Angular kyphosis is where there is a destruction of bone locally. Can be in any infection, can be post-traumatic, neurofibromatosis or congenital deformities. Then there is a condition called hyperlordosis. Hyperlordosis means the lordosis is increased. And how do you know that? Because the buttocks become prominent. There is a compensatory hyperkyphosis in the thoracic spine and a flexion and of the hip and knee. And the common causes are physiologically. Sometimes patients have ligamentous laxity, Ehlers-Danlos syndrome, Marfan syndrome, pregnancy, obesity, and spondylolisthesis. There are some people who love hyperlordosis. Can anybody tell me which are the people, which is a profession in which hyperlordosis is appreciated? Sorry?
Bollywood actresses.
Absolutely. So what happens is that when you hyperlordose, and you wear a heel, so they wear heels. Why do they wear heels? Because the moment you wear heels, not only you look tall, but your body goes back forward. You then have to bring it back hyperlordosis, so your buttocks stick out. And that is what they want. They want to look better that way, and that is the reason why there is a physiological or attempted hyperlordosis by these catwalk bodies. Okay? So remember to inspect from all sides, front, back and from the side. That's another thing which all students do. Sir, I saw the patient from the front and then he was standing straight. But when I saw the patient from the back, then he goes, nothing doing. At the start of the examination, sir, patient was examined in the supine, prone and sitting standing position from the front, back and side. एक बार बोल दिया, फिर हर एक सेंटेंस में बोलने का जरूरत नहीं है कौन सा पोजीशन में तुम एग्जामिन कर रहे थे. Okay? On inspection, look at the spatial spasm. You will find that there is a deepening of the central furrow of the spine. Okay? Look for any swellings, if there are any paraspinal swellings, any midline swellings which would indicate problems. Look for any sinuses, and whether there is any discharge from any sinuses, any hairy patches. What does this hairy patch indicate to you? Spina bifida occulta, which will be there, and look for any scars from previous surgery. Examination, temperature, tenderness. Examine the paraspinal muscles for spasm and tenderness, and then confirm your inspectory findings. Look for all the movements. I think I want to stop now and give you a chance to present the case rather than going on and on. I can go on, but I am also tired, so let's just take the case. All right?
Yes,
Sir, ruk jo.
I think it's better to take a case.
Yeah, I think so. It is tiring also now. I don't know. So let's, then if necessary and time permits, we will
Yes,
complete this. Okay? Let's take the case. Come on. Because till now, you all were making fun of me. Now I am going to make fun of you. So let's.
Go on the PPT. There. I think they have prepared a PPT with a few slides.
There are a whole bunch, Dr. Saini, of equipment over here which they never use.